Next up is another panel presentation titled Navigating Movement Disorders Associated with TANGO2. The vital role of movement specialists and families in diagnosis and treatment. The first panelist is Dr. Sam Mackenzie, a physician scientist at the University of Rochester Medical Center, where he treats patients with genetic neuromuscular diseases and oversees a lab composed of smart people who have decided to dedicate their days looking at microscopic worms. In his free time, he loves to think about TANGO2 Deficiency Disorder. Dr. Mackenzie currently serves as the chair of the TANGO2 Research Foundation Scientific Advisory Board. Please welcome Dr. Sam Mackenzie.
Thank you. Now I get to stand up here in my birthday suit. So I'm going to talk to you today about a project we've been doing for the past year and a half or so. This was a project that was funded by fundraising efforts from this foundation. And some of the work we've done on that front, a little bit of work left to do, and why it matters. And I'm hoping to set the table up for more of a management discussion from the next two speakers, and then have some time for Q&A about all of these movement-related symptoms of this disease, whether it be ataxia, dystonia, spasticity, or something else. Let's see. Hope I don't have a switch on the slide. Switch on the side. Got it. That should do it. None of these disclosures are relevant. You can see them. I don't care. So I had the same talk, or same slide, something similar 2 years ago. And I think it's important to remember that words matter. And the words we use in the medical context especially matter because they have the ability to trigger somebody's ideas or history with a certain condition. And I'll give you a couple examples. So on the left, we have an eye, and there's a small little brownish orange ring around that eye. And you might not think anything of it. It might be normal. It might be something you've always had. On the right, we have some white lines in somebody's nails. So you might go to your doctor and you say, hey, my eye's a weird color. And they say, well, put some drops in it. Or you might say, I've got these lines in my nails. Well, maybe we'll send you to a dermatologist. Maybe they'll figure it out. But both of these things, this is just an illustration that these things have names. And these names are on our tests as doctors, that we have to know an association between a Kaiser-Fleschner ring, which means Wilson disease, which is a disorder of copper transport, or mesalines, which can indicate arsenic or lead poisoning. So what do we call these? And I think this is one of the central questions that really motivated this project. In full disclosure, I should have put this on my second slide. I am not a movement disorder specialist, even though it commonly gets confused with neuromuscular. But I think this is a real key to understanding this disease and increasing our kids' chance of getting that diagnosis before they land in the ICU. And so how do we approach this, right? So these events happen episodically. It's not constant. These events are unpredictable. You might be out on a walk and not have your cell phone with you. So it's a challenge. It's not something we can have somebody come to Baylor and sit down with a neurologist, because that doesn't happen in the room. So what we've had to do is rely on all of you to send us videos, in some cases, on an old camcorder, you know who you are, and go through those videos and just try to put names to these things that we're seeing. And this wasn't me that did this. We recruited some very capable pediatric movement disorder specialists. Started with just at Rochester, then we brought in Dr. Hall at Baylor. And we literally sat down, everybody scored all these videos. They said, what is this? And we got together and we had a cage fight and we came to consensus. And and basically put labels to these, what we call phenomenologies, or these movements that we're seeing. And then as a second phase, because we're only getting a snapshot in time, we went back to some of you and asked, hey, it looks like this is this. Have you heard this term before? Is this comprehensive of everything that you've seen in your child? When did this happen? Was this the first symptom of TANGO2? When did you start taking vitamins? Did these get better? Did they not get better? And so I'm going to show a few videos of examples of some of these phenomenologies. And this is dystonia. And dystonia just means some uncontrolled muscle tone. But it's a little bit more specific than that, because it arises from a part of the brain, typically known as the basal ganglia, which is deep in the brain. And this is like an overdrive of signal going to those muscles that makes them contract in a certain way. And you can have dystonia of the neck, as in this case. Commonly, as we all know, there's a backwards flexion of the neck, which we call retrocollis. This is torticollis. You can have truncal dystonia, which we've seen videos of this conference, or you can have dystonia in a limb. And we've seen all of these in TANGO2. So this is another movement phenomenology known as ataxia, and this is the drunken sailor gait, or that wide-based gait, or that discoordinated gait. But ataxia can be very profound, and I've talked to some of you who've had children diagnosed with episodic ataxia. It can be due to a number of different genes, but it can be very severe. And then finally, we have these guys. So there might not be wobbly gait, there might not be abnormal muscle tone, but there's just that profound fatigue and weakness. And when we took this to our group of specialists and we said, what is this? What movement disorder phenomenology does this fit with? They didn't have an answer. So we're still calling these spells. And I'll say that we've actually taken videos of your kids, with your permission, to international conferences, one in Barcelona, which is just for pediatric movement disorders, and also to the Child Neurology Society. And when we showed it to the Child Neurology Society, there's a room about 3 times as big as this with experts from across the country. We've showed these videos. They've said, I'm stumped, tell us what this is. So if that makes you feel better about your physician's confusion, know that it stumped the best. So we're still working to close out this project. We've got videos from 28 patients. Hard to read these, but there's also a poster with some of our preliminary data. By far the most prevalent movement disorder that we've seen in TANGO2 is dystonia. Granted, this is a biased selection of patients, because if you had a movement disorder, you're probably more likely to send us videos. So we can't make prevalence estimates based on these data, but we can say relative to some of the others, dystonia is probably the prevailing movement disorder. Ataxia in about 1/3 of kids, 2 subjects without movement disorders in video, and then 7 with multiple different phenomenologies present. And again, one of the highlights being that these spells don't really fit with dystonia, ataxia. They can go with those things, but the weakness and the fatigue is something else. We know that movement disorders commonly occur between 1 and 1.5, sometimes earlier, sometimes later, but they commonly precede metabolic crisis, not always. But in those, I'm going to throw out a number of 90% or so kids, that's an opportunity. And we've talked a lot about early diagnosis. And so putting these names to these conditions, to these symptoms, and putting it on the radar of those people that are capable of sending off the appropriate testing is going to get more kids diagnosed before they land in crisis. And then I think the other encouraging thing that we're learning on these interviews where we go back and talk with you, because again, these are just snapshots in time, it's so helpful to have the context from those interviews. We're learning that the vitamins also help with these spells, and dystonia, and ataxia. So just to drive this home, this is not a complete list. About 2.5 years ago, we started working some outreach efforts, Seema and Ann, myself and a few others, to notify these genetic testing companies that, hey, this is a common symptom in TANGO2, you need to have TANGO2 on your panel. And we made some headway, but there's work to be done. And this is a call to action for our early diagnostic, early detection and diagnosis committee, and everybody. So just wanted to thank a few people before I introduce our next speaker on the panel. Notably, the people in my lab, Sarah and another medical student, Sam Myers, have really taken the initiative on doing all of the legwork and scheduling these interviews and conducting the interviews, and we're compiling data together. Jen Vermillion and Angela Hewitt, both at University of Rochester, and Miriam Hall have been our pediatric movement disorder experts. And then we've got a lot of help from Masha Dezamian, particularly with the subject recruitment, and of course Seema and Christina for running this natural history study and getting it off the ground in the first place. And it's just great to have a team where there's a collaborative spirit and we can all use our talents appropriately for the greater good. So I really look forward to hopefully getting this story out in the literature, broadcasting it far and wide. Largely because I think we can pick up more of these kids if we can be clear about what we're seeing. So that's it. Thanks. Okay, I'd like to introduce our next speaker, Emily Uduezue. She obtained her doctorate in occupational therapy from St. Catherine University in 2019, and she works in the pediatric setting with caseloads in both the public school setting and as an independent contractor for an outpatient clinic. Emily is a special sister to her brother Tyler, who is a TANGO2 Deficiency Disorder Warrior. Please welcome Emily. Slides down.
Wonderful.
Yeah, it's just a hazard.
Okay. Fantastic. All right. Hi, everyone. Can you still hear me? Okay. Okay, good. All right. Sorry for looking like a hot mess express. The session before that, I was in the writing one, and it was like group therapy. So we all sobbed a little bit, so I'm sorry. Hopefully my mucus will be okay. Okay, so I am going to talk to you guys about therapy. I'm obviously an occupational therapist by my job, and so I just wanted to talk to you guys about therapy across the continuum, like what the options are. This is predominantly for the United States, but I know there is other therapists abroad. It just might be in different domains, different levels, so it's just something to be aware of. And this is, do we hit this button? Oh, yeah. And this is mostly about like my brother and his journey and what we've had, but I also, being a therapist, can help you guys also. So different kinds of therapy. There's three main ones within the United States that are across the continuum. So there's physical therapy. They focus a lot on gross motor, so a lot on like what Dr. Mackenzie just talked about, like the gait, the ataxia. They work on coordination, balance, core strengthening. And then on the flip side, there's speech therapy, which is a lot of communication. They work on communication devices. They can work on feeding. And then you have us as occupational therapists, and we're kind of in the middle. We're like a jack of all trades. So we look a lot of activities of daily living. So you're dressing, bathing, grooming. We also look at some cognition. We can work with vision, higher level functioning, sequencing, sensory motor. So I know like in one of my groups earlier, they talked about like the sensory component of like, loud noises, certain textures. We have a whole sensory motor integration approach we use. So we kind of like bridge the gap between both types. So that's just my disclosure saying that like, you guys can do what you would like for therapy. This is just kind of an informative session to let you know of the options. Our personal journey has nothing to do with like me personally being a therapist. So these are pictures of my brother throughout the slide. I hope you guys all enjoy nostalgia down the road here. When he was diagnosed at 18 months, we did get early intervention at our house. It varies state by state. I know for us in the state of Maryland, that's where I currently reside, it's called infants and toddlers, but in New York State, it's called early intervention services. And again, it is physical therapy, speech therapy, occupational therapy. Sometimes they have caseworkers, social workers, nurses that can work with you. They come out to your house. They're really good at giving you, different activities, exercises to work on. They're very good with helping you navigate, especially like this difficulty of you understanding that your child is not up to the current developmental standards, and a lot of that like grief and things that we've mentioned earlier in the conferences. And so that's very helpful. They can help you also, as you can see, like my brother has a walker in the one picture. The physical therapist helped get us a walker, helped write justification letters. They're good at helping you also if you need orthotics for like toe walking or anything like that. They're good at getting you in touch with the right people and also helping you throughout the developmental milestones. Then typically students start school, so there's also school-based therapy. Again, occupational, physical, and speech therapy are the most common. They do have vision, deaf and hard of hearing, other type of services as well in schools, just depends on the school system. But they typically look at a lot of academics, helping them access their academics, looking at their school day, what do they need? Is there any equipment they need? Is there anything within their school day that needs to be modified in terms of like rest breaks, distance between classes, different things like that. It's a very team collaborative approach within the school system, and then there's also IEPs. So I know quite a bit of you probably have done IEPs where you go and you make the goals for your students, and it's supposed to be a very collaborative effort with like getting the input from the families of what are your goals for the kids, also what are the goals academic wise, and kind of bridging that gap in between. You focus less in terms of like the ADLs, like helping them, with their daily functioning, and it's more of like functioning within the school environment and how to get them to reach that level. Then when they graduate, like my brother currently is, he's 24, so he actually receives outpatient services now. He gets outpatient speech once a week and physical therapy, I believe twice a week. Yeah, I'm saying yeah. Twice a week. So he goes to a clinic, and they also, right now his speech works with him because he's nonverbal with communication devices, working with him in terms of navigating the device, working on, nonverbal communication. Physical therapy has been very essential for him since he's been out of school in terms of stretching. He also does receive like Botox injections for spasticity. I know Kara in a few minutes is going to talk about that. So that's been very helpful in terms of getting him stretching, also helping us as families when he's having some difficulty with mobility or different difficulties that have shown up for him post-school that we've been navigating as a family. They've been a great source in terms of helping us get the right testing we need, get us in touch with the right doctors, the right medical teams. So even though when your kiddos get older and they graduate, there's still services in the community that you can do. And a lot of outpatient therapy can be covered with insurance. There might be co-pays and things, but there is a level of assistance there. School-based is typically free. It's through the school system, so you don't have to worry about that. Early intervention is usually also free of services, or it's very limited co-pay. It just depends by your state. The few times that he has been hospitalized for prolonged, like expected prolonged time, this is actually during a time he had a brain tumor taken out. There is hospital-based therapy. I used to actually be a hospital-based therapist as well. So we can go in and help them see like if there's any new deficits following a hospitalization stay, ways to kind of get them back to baseline, help the family in general with transfers. So if they seem a little bit more weak, helping you guys navigate what kind of equipment you need to get them home safely, make them comfortable safely. There's also in the hospital, they sometimes, depending, have like a music therapist that can come around, a child life specialist, things to help raise their moods, interact with them in a different way and in a healing pattern. But there always is like a speech therapist, an occupational therapist, and a physical therapist in those settings as well. And then the other things that he has personally partaken in is aquatherapy when he was younger. It's pool therapy, for layman's terms. You get into the pool and they are able to like help walk around, they help to kick, they help to work on strengthening of your muscles in different ways. And that's usually via either a physical therapist or an occupational therapist. And it's also not usually covered by insurance, so it's something to explore if you want. And the other thing he did growing up was hippotherapy, so that's therapy with horses. And that was to help, with his pelvis and help like move his hips in a little bit of a different pattern because he was so tight growing up. And so that one, you know, you get to not only care for the horses and learn how to care, but then also learn, you know, like to ride a horse, and he gets to learn his body passively, how to advance and how to stabilize and maneuver that way. So just a different experience, but not always covered by insurance either. So it's a little financial things. But I think, yeah, that's it. Oh, sorry. So that's it for my section. And then our next panelist is going to be Kara Cameron. She's a mama to Braxton and a TANGO2 Warrior Bria. She's the treasurer of TANGO2 Research Foundation and sits on the research, fundraising, and executive committee. She's also a president and founder of the Canadian TANGO2 Rare Disease Foundation. So please welcome Kara Cameron.
Hi, everyone. Thank you. I do not have a disclosure statement. I am an accountant and completely unqualified to give any sort of medical advice, so that's my disclosure. But what I am an expert on is my little Miss Bria. So I thought what I would do is give a bit of a parent's perspective of navigating mobility challenges. And I did want to start with a little bit of a poll. How many of the parents or children have experienced Botox injections? So quite a few. So that's really what I'm going to focus on today. So a bit of a background, and so that you understand Bria's journey. Bria is now 10. At the age of 4 months, she had her first metabolic crisis. And then at the age of 7 months had her second metabolic crisis. The second was much more impactful than the first. We almost lost her 11 days on life support, and when she came out of that experience, she had less mobility and tone than she had when she was first born. So it was a long journey back from that. Bria did not walk until she was at the age of 3. And I'm really glad that Emily brought up hippotherapy. So Bria had an array of different therapies that we tried, from walkers to walking assists. I think our hospital is called the IWK. They even brought a hula hoop and plungers for her to try and walk with, and nothing was happening. And so Bria at the time was about 2.5. Had took a long shot on hippotherapy. So I had a friend who was also an accountant who said, my sister loves horses. She's got this little pony. He's about 30 years old. He's not going to move fast, and she's willing to put Bria on this horse. And, you know, a 2.5-year-old on a horse was a little bit nerve-wracking for me at first, especially one who could barely sit up or walk. But we tried it. It was a last-ditch effort. And on Bria's 3rd riding lesson, we came home, and that day she took her first steps. So it was an incredible moment for us. They talk a lot about the brain-body connection with hippotherapy, and the movement of the horse mimics and allows that to translate down to the lower extremities. It strengthens the core, and has provided a huge benefit to Bria over the years. So Bria, instead of going to school on Tuesdays, actually does horse therapy on Tuesdays for approximately an hour, and again gets the benefit of the riding lesson, taking care of the horse. It gives her confidence, and so that has been a really, really big game changer and life changer for Bria. Before B vitamins, Bria definitely struggled. Bria was actually in one of the videos. She was the last video that you saw on Dr. Mackenzie's slide deck. So she definitely struggled a lot with mobility and strength in her core and lethargy. So B vitamins really brought her around and have assisted Bria in coordination and getting through the day and really practicing that strengthening. Over the past, I would say, 2.5 years, we did notice a progressive decline in Bria's ability to stand flat-footed or walk from a heel-toe perspective. And so what Bria would do is she started to come up on her tippy toes, and we used to call it toe walking or tippy toe walking. And again, thank you to Dr. Mackenzie's excellent progress. We're starting to get language to be able to describe that to doctors. And so there was a couple of different things we called it other than that. So spasticity, high tone are some of the languages and words that we used now to describe what Bria had experienced. And I would say probably 6 months ago, Bria was unable to put her foot down flat foot at all on the right side. So still really, really tight on the left side, but the right side was completely restricting her ability to walk flat-footed. When we talked to our physiotherapists, they referred us to what they called a rehab clinic in the hospital. And they used words like rehab doctor, physiotherapist, rehabilitation center, and I had never heard of this, a physiotherapist or a physiatrist. So all new language, new words to us. But what they recommended to us was Botox injections. And so this was a little bit scary for us as a family because they said in order to receive the Botox, Bria would actually have to be put under an anesthesia. And so as we all know as parents, any sort of time we have to get an anesthetic as a TANGO2 child, it's extremely unnerving. It's a scary process. Lots of planning has to go into that, from what the anesthesiologist has to do to how we prepare Bria for the surgery, to how soon before the surgery she can have liquids, diet, medications. So that process was, I would say, a difficult one and a very anxiety-provoking one for me and her medical team. So we had multiple meetings, multiple letters written between her geneticist, her cardiologist, her physiotherapy team, as well as the rehabilitation doctor and the anesthesiologist. So that did take time and effort. We ultimately decided to pair it with a dental surgery. Bria needed some dental care. Her teeth did not develop correctly when she was in metabolic crisis, her molars. And so we kind of did a double whammy. But what I will say is that we were very well taken care of. There are protocols. That protocol letter really helps. The doctors are very receptive to our recommendations and asks around B vitamins. She was able to receive sustenance up to an hour prior to going under, and so all of that, they were, because of the work we had done with the foundation and because of the doctors and the letters, they were really good to help us through that process. So the surgery did go well. Bria struggled coming out of the anesthetic, I would say. She had close to 10 hours of vomiting. She was quite upset after coming out of that surgery, I think primarily due to the dental. She never once complained about her leg. So Bria received Botox injections on her right leg from just in the calf area. They did not do the foot, and they did not do anything above the knee. And so we felt that the surgery was a big success. The next day after the surgery, we noticed that Bria went from like that tippy toe walking to being able to come almost halfway to the floor, and then all the way to the floor very shortly afterwards. The surgery was, you would think that was the biggest task, but it was actually the casting after the surgery related to the Botox that was the larger task. So once she was a week post-op, we had to go back to the hospital, and she had to put a walking cast on. And so this was I guess I had always envisioned something really hard and plaster, and I don't know if I was back in the 1950s in my head, but I guess I was. Lots of progression has been made. And so it was fairly quick. We went to the rehab center. They wrapped Bria's leg, put a kind of sleeve on first, wrapped Bria's leg, and then she was in her first cast for 7 days. We were able to actually remove the cast at home, which is a very simple process. You kind of just picked at one of the edges and unraveled it, and it was off within a matter of 2 to 3 minutes. So there was no having to go back to the hospital or cut it off her leg, no scary sounds or noises. So that was pretty platonic from an experience for Bria. What was not platonic was going back in 4 days and getting another cast on. And so what they really want to do is post the Botox injection, have multiple weeks of casting to ensure that they are lengthening the muscles. And again, this is parent speak, and doctors and scientists just probably close your ears to the way I describe this. But it was really to get her to that 90-degree angle. What they didn't want to do was overpronate, so they didn't want her to be able to kind of bring her foot up like this, but just be able to keep it at the 90. And so they said that it could take up to 4 casting sessions. We were lucky enough that Bria actually had phenomenal success in only after 3. And so after those 3 sessions, she was done of the casting. The next step, though, was to go and get her braces. And so after Botox, in order to maintain that success we had after casting, they really wanted her to be braced the majority of the time. And so these are Bria's braces. I just brought them so that everyone could kind of see what they look like. I'm sure some other parents are familiar with the way these look and on their children. Bria's are quite pretty with butterflies, but they are not super comfortable. And what I would say is, so they took 6 weeks to actually make and mold. And so that was a bit of a process again. And then the next hurdle was actually getting Bria to wear these lovely things that were prohibitive and inhibitive for her, and in Florida, quite sweaty. So when I was taking them this morning, she was like, "What are you doing, Mom, with my braces?" And I was like, "Well, I'm taking them with me." She's like, yeah, she was pretty excited about that. She was like, all done with her braces. So yeah, that is one of the, I think, the largest challenges is, as a parent, you get something from a doctor and they're like, you need to do this, she needs to have these on, and then you're left with the outcome of actually trying to get a highly mobile, very stubborn child to put on plastic things on her legs that go from her toe all the way up to her knee. And so we are having more success at school. I think peer pressure is a really thing, and bribery works really well for Bria. So we have an enormous amount of dolls as a result. Not that we didn't have a lot before, but it is something that, and you're going to see it. I'm going to have a video here in 1 second where you'll see after her first casting session, one of the doll excursions. So I guess really what I wanted to let everyone know is it's not easy. It's not an easy process for sure. It has been incredibly worthwhile. So Bria can jump now, which was a massive accomplishment for her. And a bit of that kind of motivation was she would be able to jump like her brother. And so that was something that really motivated her to wear the casts and to wear the braces. Just be patient with yourselves. I try to be patient with myself for sure, and patient with your child. I know that it is quite an accommodation for Bria, but definitely worth it. In the end, we saw great success. So I just wanted to give you a little bit about our journey. Lots of people in the audience have also had similar journeys, so encourage any questions or comments when we had our panel session. What I will do is her big brother did a little video, so I can take 0 credit for this. He's the technology guru in our family, but this is a bit where you can see Bria prior to Botox, during the casting process, and then how she's doing today. She was ready for Disney a long time ago, obviously. So 4 months post Botox, she is slightly up on that right, which is where we get the help from the bracing. And that's the end of my presentation. So.